Greetings. I would like to share an interesting case. Unfortunately, the original recording did not go well because of some issues with the computer. And I would like to thank the panelists who participated in this meeting today. That includes Selvi, Sylvia, Ravi, Sriram, and Joseph. And I would like to acknowledge the support of Dr. Stroline, Mr. Charles Butt, Ms. Angela Dio, and the University of Texas MD Anderson Cancer Center. So this is a complex problem. This patient underwent colonoscopy for evaluation of abdominal pain with alteration of the bowels for a couple of years and a little bit of bleeding in the stool. A polyp was found in the sigmoid colon, and that was removed by snare cautery polypectomy. And on post-op day, she developed severe abdominal pain, and the CT showed submucosal edema, not just in the sigmoid colon, but also in the entire colon, consistent with colitis. Here we see the pathology findings of the lesion, that is the sigmoid colon polyp, which revealed a moderately differentiated adenocarcinoma. Because there was no tattoo placed, and I assume the colonoscopist felt that the polyp was benign. And when she came to our center, our surgeons asked us to go back and examine the colon, find the scar, take biopsies, and also take biopsies from the rest of the colon, given the history of colitis, and place a tattoo to mark the site. As you can see, the terminal ileum and the entire colon looked normal with no features of inflammatory bowel disease. In the top panel, you notice the clean scar with no residual polyp. A biopsy was taken. I usually take a picture of the biopsy forceps pointing at the lesion, as you can see in the second panel left image, so that it serves as a good reference for us. And following the biopsies, a tattoo was placed. Basically, 3 tattoos were placed after injecting a little bit of saline into the submucosa and creating a submucosal saline bleb, and then filling that bleb with tattoo. Biopsies from this colonoscopy revealed focal active colitis in different segments of the colon, and the colon scar in the sigmoid colon that was located at 25 centimeters from the anal verge showed an erosion, mild active colitis, and crypt architectural distortion with no local cancer. Given the uncertainty about the patient's actual staging, whether there were any lymph nodes involved or not, although the CT scan of the chest, abdomen, and pelvis revealed no metastatic disease and no lymph nodes suspicious for cancer, although there were a few reactive lymph nodes in the area. She underwent surgery with exploratory laparotomy, sigmoid colon resection, and primary colocolonic anastomosis. The pathology of the resected specimen, the scar site where the cancer was located, the cancerous polyp was removed, was negative for cancer. The scar was clean, free from cancer in the colon wall. Out of 40 lymph nodes harvested, 1 lymph node was positive for cancer, and her staging became stage 3 because of the positive lymph node instead of stage 1. And I'm going to discuss this a little bit in detail later. She underwent chemotherapy with FOLFOX regimen that is conventionally used for colorectal cancer chemotherapy for 3 months, and she has done well. Coming back to the staging of the cancer, as you can see on the right side, you have the image, you have the lumen, mucosa, submucosa, muscularis propria, serosa, then lymph nodes, and viscera like liver. Uh, Cancer limited to the mucosa is stage 0 or T0. T1 extends into the submucosa, T2 to the muscularis propria, T3 goes through the wall of the colon, and T4 involves adjacent viscera. So that is the T stage. Whenever the lymph nodes are involved, irrespective of whether the tumor is localized to the submucosa or to just the muscularis propria, when the lymph nodes are positive, it automatically becomes stage 3, as long as there is no metastatic spread to either a lung or liver. When there is involvement of the lung or liver, then it automatically becomes stage 4. So for the sake of students, when there is no metastatic spread and there are no lymph nodes, then you exclude stage 4 and stage 3 disease, and whether it's stage 2 or 1 depends upon whether it's involving the muscle or not. If it is involving the muscle, a muscular layer of the colon, it is stage 2. If it is just the submucosa, it's stage 1. So the question comes is treatment of colon cancer. We're not talking about rectal cancer, but colon cancer. For stage 1 disease, there is a 10% risk of recurrence after surgery. For stage 2, 20%, and stage 3, 50%. Regarding whether these patients should receive chemotherapy or not, it all depends upon the benefits versus risks of chemotherapy. For stage 3, certainly useful, beneficial, because it reduces recurrence and death by about 30%. For stage 1, no benefit of adjuvant chemotherapy. For stage 2, there is a minimal benefit, and one worries about the risk of prolonged risk of chemotherapy-induced neurotoxicity. So how do we address this risk of chemotherapy-related toxicity? There are a couple of very interesting articles that came out in the last 4 or 5 years regarding the treatment of stage 3 disease. Typically, patients are given 6 months of FOLFOX therapy for 6 months, and that has been shown to reduce recurrence and death. Recently, there was an interesting trial that showed that 3 months versus 6 months survival, there's hardly any difference. But the big difference was in terms of the neurotoxicity that affects the quality of life. 15% in patients who underwent therapy for 3 months, and 45% for patients undergoing therapy for 6 months. So now a lot of oncologists are moving towards 3-month therapy for low risk stage 3 cancers. If it is high risk, then they try to go with the conventional therapy. The next question is stage 2. We learned that there is minimal benefit, but You could also figure out in that stage 2, although the recurrence rate is 20%, one needs to wonder whether everybody is at 20% or whether there are subgroups in stage 2. You could figure out whether stage 2 is high risk or not by checking the CDX2 in the cancer. CDX2 is a molecular profile of a particular tumor, and patients who have a low or negative CDX2 in the tumor uh, tend to do worse than those who are positive. It's also been shown in preliminary studies that those who are at high risk for recurrence, with the CDX2 being negative, when they go for chemotherapy, they have a much better survival, 96 versus 56%. So I try to share this case to show that when you look at a patient, and we have a patient with a cancer, uh, when you find cancer after resection, it's a good idea to consider proper evaluation to see whether there is a benefit of doing surgery. It all depends upon the overall general health. If somebody is healthy, it's good to have surgery and figure out if lymph nodes are involved or not. If lymph nodes are involved, then it is stage 3 disease, and stage 3 disease benefits from chemotherapy. Unlike in the past, one could get the same benefit with 3-month treatment if it is a low risk stage 3 cancer. For those with stage 2, it's a good idea to look at CDX2. That is something new that's come up to figure out whether somebody is at high risk of recurrence, and if so, consider chemotherapy. Thank you.